office hours today, and I would look forward to that. And you all can email me anytime. And you know where to find me, you know what my interests are, and hopefully get some sense of how I might be useful to you as communications unfold. Today I'm going to be discussing a little bit of a sort of a summary of the first part of my remarks today, a summary of what we've learned in the class, and then move on to sort of a synthetic effort to tie together some of the big ideas and close with some of the most difficult conundrums that I personally feel in this whole topic, which reflects in some ways a life's work for me, trying to negotiate the kinds of issues that we've been discussing. So what have we learned over the last few weeks together? We've seen first and foremost that health and illness depend critically on non-biological and non-medical factors. We've seen that from 1900 to 2000, life expectancy of birth in women increased from 48 to 80 years, and in men from 46 to 74 years. And this has been especially because of reductions in mortality at an early age, but also due to improvements at older ages. And it's worth noting that this decline in mortality, this rise in longevity, is a historic achievement for our species. But it's unlikely ever to be repeated, because we only get to conquer childhood diseases once. We've already done that. We did that in the 20th century. We don't get to do it again. We don't get again to get this radical improvement in human well-being, this incredible increase in life expectancy. And in addition, we saw that the maximum human life expectancy hasn't changed in the last century or more. It's still at about 100 years. And we saw that much of the decline in mortality preceded, often by several decades, the discovery of specific medical treatments, strongly suggesting right from the beginning of the class the important role of social change as compared with medical discoveries or advances. And we also saw a very substantial decline in disability, roughly 2% per year for the last 20 years, speaking to a compression of morbidity that is also partly due to social changes and partly to medical advances. We see that these improvements have been unevenly distributed in our society, stratified by socioeconomic status. And this unevenness also is one of the many clues, not only regarding the fundamentally social nature, but also regarding the fundamentally moral nature of what we have been considering so far this semester. As if issues of life, death, and suffering were not enough of a signal regarding this fact, were not enough of a signal regarding the fundamentally moral issues that we've actually been talking about the past few weeks. We've discussed how a society may contain different starting positions into which people are born, many different destinies which people are fated to have. And we must ask the question, how are we to know if this is just? The workings of the natural and the social lottery, that is, the workings of forces outside of the individual, in determining individuals' health, cannot possibly be justified by an appeal to merit or desert. They cannot be justified on utilitarian grounds either. So how are we to justify the birth with a disability or the birth into a poor family that limits a person's prospects? As philosopher John Rawls has argued, it is to these inequalities, presumably inevitable in the basic structure of any society, to which the principles of social justice must in the first instance apply. Rawls argues that justice arises when, quote, all social values, liberty and opportunity, income and wealth, and the bases of self-respect are distributed equally, unless an unequal distribution of any or all of these values is somehow to everyone's advantage. In fact, I would suggest that liberty and justice are indeed social phenomena. We're generally not interested in considering whether you are free from nature. And we're generally don't generally speak of nature as being unjust. We speak of people being unjust. We speak of you being free from the effect of other people. So these social values that we think about, justice and liberty, for example, are inherently social. We are interested in freedom and justice as they pertain to the actions of other humans. And accordingly, to the extent that health is a social phenomenon and a social value as well, and to the extent that it transcends our biology, its occurrence and distribution raise questions of social justice. With respect to what the factors beyond individual control foreordain, we've seen many things. We've seen that exposures to poverty or malnutrition, even prior to your birth, can affect your risk of developing illness decades later. We've seen that whether one even survives the neonatal period depends on the race of your parents, or their education, or on a host of other factors over which one has no control, such as your birth order. We've seen that how genes affect you can depend on your environment, and that genes may be regulated by social exposures. We've seen that social circumstances, such as your schooling and your wealth, are not only affected by, but actually more considerably affect your health. We've looked at several health-related behaviors and seen how they are a product not only of individual choices, not only of individual agency, but also of one's social circumstances and social structure. We've seen how obesity and smoking, for example, are socially patterned by race and income, and how they are strongly influenced by factors outside the individual. We've looked at more complicated social circumstances too, not just these sort of basic variables that I've just been describing. We've seen how your health can depend on who you know, where you live, and what the people around you are doing. So we saw, for example, that income inequality, which is measured at a collective level, which is not a property of you yourself, how this too could affect outcomes as diverse as maternal depression and longevity. And we've seen how other sort of social structural factors into which we are embedded, things like social capital, also measured at, for example, the state or even a more micro level, were associated with mortality at the individual level and reflected our collective ability to maintain both individual and collective health. And we've seen how local norms and local culture are also crucially important in determining what happens to you, what health experiences you have, how your body functions, and so forth. We've seen that neighborhoods also matter, affecting whether one becomes depressed, falls ill with heart disease, or dies, even after accounting for clinical and social risk factors measured at the individual level. And we've seen other environmental factors, such as pollution, exposure to secondhand tobacco smoke, traffic patterns, and crime can also be important. And in terms of who you know, something that I'm so interested in and so obsessed with, we saw evidence that one's health behaviors, whether related to smoking, drinking, drug use, exercise, and weight status, are strongly influenced by the behaviors of those around you. Even people beyond your social horizon, people to whom you're not directly connected, at 2 or 3 degrees removed, 2 to 3 degrees of separation removed from you. More generally, we saw that one's health depends on the extent of one's social support and on the nature of one's social network. Isolated individuals, separated from society, fare worse, and the more socially integrated one is, the better for one's health. Now, it's also true, inescapably true, that one's health also depends on medical care. This must be acknowledged. But medical care is not uniformly good, nor uniformly available. And we saw evidence for both the benefits and the harms that can arise from medicine, and for the potentially capricious play of physician decision-making in one's health. Moreover, we saw that despite our terrific healthcare system and the billions of dollars that we spent, between 40 and 70% of Americans die in pain. And surely, in my judgment, this is an enormous failing of our civilization. In short, not only do all these social factors influence whether you fall ill, not only do they influence the course of your disease and recovery, but also they influence how doctors treat you and even how you die. Seeing all these things another way, collecting all this together, and looking at it a different way, from 1900 to the present, only about 5 of the 30 years of increased life expectancy can plausibly be attributed to better medical care. So we've gained 30 years in the last century, but no more than 5 of that is attributable to advances in therapy or diagnosis, or what we customarily think of as big medicine. A different estimate that starts the clock in 1950, a much later starting point, judges that medical discoveries and implementation of medical innovations account for not more than 3 of the 7 years more of life expectancy we've gained since 1950. Now, 3 years is a big deal at the individual level and certainly at the population level. But the point is that health care, in fact, is not the main driver of health in our society. And in summary, the causes of wellness in Americans can be partitioned as follows. I think this is taken from your readings from today. So if you want to look at the factors that shape our health care, genetic and gestational endowments account for about 30%. Social circumstances about 15%, environmental conditions about 5%, behaviors about 40%, and medical care only 10%. Reviewing the list from the top, we see that less than 2% of deaths are due to purely genetic diseases. And while as much as 60% of chronic disease, such as diabetes or cardiovascular disease or cancer, may have a genetic component, most of the time it's other social and environmental factors that co-conspire with our genes to determine the kind of health experiences that we have. Less than half of the time are genes solely explanatory, as borne out by twin studies, some of which we've seen this semester. And many gestational factors are themselves related to the social and environmental circumstances that are considered further down on the list. So even though we might say 30% are due to genetic or gestational endowments, even that is too much, probably, in apportioning factors that determine health, overestimating the importance of genes in these outcomes. Social circumstances, second on the list, as diverse as education, income, housing, crime, social capital, religion, and occupation, are highly relevant as well. Indeed, poverty alone probably is directly responsible for 6% of the mortality in the United States. 6% of deaths overall probably can be ascribed just to the fact that some among us are impoverished. Environmental factors, third on the list. Environmental factors as diverse as toxic agents, structural hazards, chemical contaminants of food and water, pollution, street and urban design, and so forth account for another 5% of the factors shaping our health. Motor vehicle accidents would fall in this category, and environmental factors can predispose you to infectious diseases such as tuberculosis and have other manifold ways of killing you. Behaviors on the list related to exercise, sex, substance abuse, safety precautions such as seatbelts or helmets, and smoking are by far the most important, as we have seen. And they involve both individual agency and structural constraints in determining how individuals act. Finally, medical care is important too, but it accounts for only a fraction of the preventable deaths. That is, only 10% or so of the deaths in our country could be avoided by a greater availability of medical care or better such care. It's just not about medicine what makes us well, what contributes to population health. And all of the foregoing can be mapped onto our biology, of course. And as we've seen, we come to embody these factors. After a life of smoking and poverty, how can their effects on our body possibly be seen as irrelevant or ignorable? These forces get under our skin, literally, and we are increasingly in a position to understand how this happens. In my judgment, a key topic of research in medicine and biology in the coming decades will be to figure out how this happens. How might poverty, or child abuse, or malnourishment regulate our genes quasi-permanently, for example? And thus we saw evidence for a kind of social epigenetics, whereby our genome comes to be regulated by social exposures over the course of our lives, and that we become marked by these social exposures. We literally embody them. We saw evidence that our genome is affected by culture over long time horizons as well, as in the case of domesticating animals, inventing cities, and changing marital rules, all of which have created selection pressures on our species and helped to reshape the kind of bodies we have over time courses that are much longer than individual lifespans. Of course, it is possible that the contribution of medical care to life expectancy, and more likely, the compression of morbidity, will continue to grow as technology is better able to address healthcare needs. But I seriously doubt it. The kind of evolution towards a cyborg existence we also discussed might happen, but I don't think we should count on it, especially in the short term. Indeed, I think that further improvements in the quality and use of medical care have a relatively limited ability to reduce deaths in the United States. And this is not too, or should not be too surprising, because as we saw, we already spend about 16%, more than 16% of our GDP on medical care. How much more effort could we make, or value could we expect from all this money we are spending? Is it really realistic to think that we could do any better, or make any more of an effort with respect to medical care, such that we would derive improvements in longevity and reductions in mortality than we already have? In addition, I think that ultimately, the health fate of each of us is determined by factors acting not in isolation, but by our experience where domains interconnect. For example, whether a gene is expressed can be determined by environmental exposures or behavioral patterns. And of course, the nature and consequences of behavioral choices are affected by our social circumstances. So these things are even more complex than we've been discussing, intersecting in complicated ways, affecting what happens to you, so that each of the things on this list interacts with the others, all contributing to the kind of healthcare we have as individuals and the kind of health we observe in populations. So at the population level, social conditions and behaviors are more powerful determinants of health, than access to care, by which I mean not only having insurance coverage or the means to pay for medical care, but also the opportunity to use it. I mean more important than medical care itself, these social factors are. Limited access to medical services, while problematic, unjust, and reprehensible, is not the primary basis of ill health or even of socioeconomic disparities in health. So this is the second big point that we've been considering. And we know this is the case for a number of reasons. First of all, social factors are more important in explaining health outcomes than clinical factors. So it's not the clinical care that can explain more of the variance. Second, there are widening disparities in health status according to socioeconomic status, even in Britain, where there is universal access to health care, or even in the United States after the introduction of Medicare, as we also saw earlier in the class. So again, socioeconomic factors are more important than access to medical care in explaining the disparities. Third, the effect of socioeconomic status on health status persists even after adjusting for access to medical care. So SES is a fundamental cause of health. A third reason that we can understand that limited access to medical services is not the main driver of socioeconomic disparities. The fourth, even in a setting of a clinical drug trial being conducted by doctors in a hospital, which is about as safe and elite situation you could be in. You're a patient, you enrolled in a drug trial, you're being cared for by doctors in an elite environment, in a very supervised way. Even we saw patients like that who get care in that fashion, even among them, there are socioeconomic disparities in health, right? The patients that are poor or less educated or have other kinds of features, they fare worse, even in that environment, which is giving everyone a very standardized, high-quality healthcare experience. So for all of these four reasons, we know that medical care does not explain or fully explain socioeconomic disparities in health. In short, while biomedical care might be effective in acute and inpatient settings, in chronic disease and outpatient settings, it's less effective. Thus, a focus on access to healthcare professionals ignores the most important determinant of health, the patient, him or herself, and his or her sociocultural context. Other things are changing in medical care too that further encourage the foregoing neglect of the real roots of illness. So why? What are some reasons we're neglecting these fundamental causes, these real causes of illness? A number of things are happening that I think sort of abet or contribute to this ignoring. Progressively, over the latter part of the 20th century, physicians have increasingly become bureaucratized. Physicians have increasingly been seen as functionaries and technicians, increasingly divorced, I think, from the moral and social aspects of their work. So it used to be that doctors had a lot of agency, were seen as moral actors, were seen as concerned with the experience of their own patients. But progressively over the last 100 years, we've turned them into employees. We've bureaucratized medical care. We've come to see doctors as technicians. And this unavoidably has divorced physicians from these other more ancient roots of their practice, more ancient ideas about how doctors are to act. And in addition, there have been changes in medical epistemology, in how medical knowledge was created and organized over the last century, which I think also has made us less able to see the social determinants of illness. For instance, over the course of the last century, physicians began to believe that two different patients might have, in a very fundamental sense, the same disease. Medicine progressively moved from an individualistic notion of disease to one concerned with the centrality of diagnostic categories based on specific causative agents. This development in clinical thought was associated with a substantial increase in the attention to making diagnoses and prescribing targeted, specific treatments. Conditions began to be seen as having identities independent of their existence in individual patients, and there was a relative decrease in the attention to patient-specific factors. So this change in how we saw diseases, a good scientific change actually in my judgment, led us to no longer focus on patients themselves, led us to see different patients as having the same condition. And this change, plus the discovery of manifestly effective treatments for disease in the last century, both worked to shift clinical attention away from the individual patient and towards the diagnostic category and the corresponding therapy. In fact, attention is directed to what is deemed to be the essence of the problem. And this leads to a clinical gaze that is through the patient rather than upon the patient. The patient becomes not so much a sick person as rather an endlessly reproducible pathological fact, to borrow a phrase from Michel Foucault. So both of these changes, bureaucratization of medical practice and the shift away from seeing patients as distinctive, the latter of which is partly required for the kind of scientific advances we've had in the last century, have helped to shift our focus towards aspects of patient experience that deliberately isolate them from their social surroundings. So these changes, you see, have led us away from and make it more difficult for us to see the actual real importance of these social factors in determining health at the individual and population level. Lead us to focus on the medical care and lose sight of everything else that is so much more important in determining health. So a focus on healthcare rather than on the real determinants of health and illness, when coupled with these changes in the practice of medicine and the role of physicians, can lead to misguided public policy. And this picks up an idea we also discussed earlier in the course. This isn't just idle theorizing about sort of medical epistemology. These things matter. These visions, these perspectives, these understandings of the determinants of health lead us to implement different kinds of policies that change the experience of every one of us and that change the course of our society. In my judgment, to truly improve health in the population, physicians must serve as advocates for improved social conditions, for public health initiatives, for general and health education, and for behavioral interventions. And the reason should be obvious by now. Illness is a social and not just a biological phenomenon. And as such, it has social origins and may have social cures. Now, identifying the roots of a problematic social phenomenon invites consideration of solving it. And while it is also true that that which explains something may not necessarily be that which solves it, it seems clear that we need to pay more attention to issues of public health. When a social factor is seen to increase the risk of disease onset, or the risk of bad outcomes given onset, then the opposite factor is typically seen as having the opposite beneficial effects. Current developments, I think, in the social sciences may help actually shed light on these topics, shed light on the determinants of health and the impact of healthcare. And we are, I think, in the midst of major changes in this regard. Now, I think also for the past century, people have looked to the physical and biological sciences to help solve important problems and to advance human welfare. And we've had enormous discoveries in the last century in antibiotics and plastics and computers and so forth, which have had radical impact on our society and on our well-being. But I think that actually in the 21st century, the social sciences offer equal promise for improving human welfare. Human lives can be substantially improved through a deeper understanding of behavior and its fundamental biological and social origins. Now, traditional research for hundreds of years in the social sciences has generally favored observational rather than experimental methods, leaving aside psychology, which has always had a tradition of experimentation. And such traditional research has generally involved special subsamples of people rather than entire populations. And traditional research in the social sciences has generally tended to neglect the role of biology. But I think all three of these things are changing in radical ways, all of which we've also seen this semester. So first of all, I think a biological hurricane is approaching the social sciences. I think that new discoveries in genetics and in neuroscience are going to force a rethinking of fundamental social questions and lead to new vistas in understanding why are we the way we are? What explains individual and collective phenomena? And analogously, I think that progress in the social sciences are raising basic biological questions. For example, the very demanding and difficult problem of understanding human cooperation, which social scientists have been interested in for a long time, is now becoming increasingly biologized. And this progress affords an opportunity to build what I think is a new synthesis of biology and social science, one that avoids the extremes of strict biological determinism on one hand and strict cultural constructivism on the other. And I think that such a synthesis would transcend the false division between nature and nurture, and it would allow us to understand the causes of human behavior in a much more complete and powerful way. So that's one of the three big things I think is happening in social sciences. First, a biological hurricane is approaching them. But there are other things happening as well. So second, it's clear that we are increasingly living in a world of pervasive data. And this has led to the advent of a new kind of computational social science. We've also seen many examples of this semester. If you had asked social scientists even 20 years ago what powers they dreamed of acquiring, they might have cited the capacity to inconspicuously track the behaviors, purchases, movements, interactions, and thoughts of whole cities of people in real time. And of course, that's exactly what is possible nowadays. Now that so many of us, because of credit cards, cell phones, online social networks, employer records, health information systems, and so on, move through our lives and leave little digital breadcrumbs behind us, allowing social scientists and others to track and understand individual behavior and collective phenomena in a way never before possible. Such massive passive data will revolutionize our ability to understand behavior. That's the second way of changing. And third, something else we saw in this course, the social sciences are increasingly rushing to embrace experiments both in the lab and in the field. The great majority of traditional work in the social sciences, again outside psychology, has involved observational data and not the controlled experiments that are so common in the natural sciences. But it is now possible to use the internet to enlist thousands, sometimes millions of people to conduct online experiments, to randomly assign people to different kinds of social exposures and see what happens. And there's a boom in field experiments where people are going to schools, to hospitals, to cafeterias, to developing world villages, and so many other venues, to workplaces like we saw, and doing experiments to see, if we do this, do we make people better? Can we have robust beliefs in how and why we might work upon the world to improve the predicament of everyone within it? And this approach is rapidly reshaping the way that social scientists translate their knowledge into practice, changing the way we think about public policy, making it better, making it so we're better able to improve the well-being of everyone. Such new approaches and new findings are certain to reshape our understanding of public policy and public health, in my judgment, in many valuable ways in the coming decades. Now, regardless of the style of research, here is why this type of shift in perceptions about the real determinants of health, what we've been considering all semester, is important. Here's why it really matters to get this right, to really understand what determines health. Well, the reason it's so important is that approximately 95% of the $1 trillion the United States spends on healthcare every year goes to direct medical services, and just 5% is allocated to population-wide approaches to illness prevention and health improvement. We spend our money according to our understanding of the world, and a mistaken understanding of the world results in us spending our money in ways that are very, in my judgment, inefficient. And as we have seen, this partly reflects an underinvestment in public goods. Decisions made at the individual level, even if rational, may lead to irrational outcomes at the collective level. As we saw with classic examples of the mattress on Route 28, the prisoner's dilemma, and the dollar auction. That is, decisions reached individually, however rational, are not necessarily best for society. And the example of the tragedy at the Commons was very fitting in this regard. Every herdsman quite rationally seeks to maximize his gain and enlarge his flock, grazing on the commons, but in so doing he contributes to an overgrazing of the commons to the detriment of all. Each person acting in his own interest and pursuing what is in fact the only sensible course of action from an individual perspective drives the group to ruin. Well, what are some of the barriers beyond barriers to implementing public health interventions beyond the public goods nature? So the first point is we have a misunderstanding of the causes of health. This results in us not spending dollars and making public policies in a way optimized to enhance public health. But even if we wanted to do that, it's not an easy thing to do because there are a number of barriers interfering with our ability to implement the kind of public policies that we might think are more enlightened. And what are those barriers beyond the public goods nature of public health? Here are some lists. Here's a list. One is that it often involves complex cost-effectiveness assessments. Trying to figure out, is it worth spending the money is not always easy. When you are sick, you will spend limitlessly to make yourself better from your own stock of resources. But at the collective level, more trade-offs are typically necessary. Another barrier is that complex interventions are directed at multiple causes, and we've seen evidence for this during the class as well. There's the problem of interest group dynamics and vague proponents. It's hard to figure out who's benefiting from what we're doing, and how can we marshal political will to advocate for changes in public policy. Broad coordination of actors outside health policy is required. Even if you go into this field and you become an expert in this field, often if you want to improve public health, you have to interact with people that work in other domains, in urban planning, in in economic development, in media, and so forth, well outside what you would think of as a conventional health domain, as we've seen over the course of the semester. And finally, social preferences. We must agree or face the reality that there are social preferences about unhealthy behaviors. It's easier and often more fun to behave in unhealthy ways. And you have to go against that too if you're going to try to change public policy and public health for the better. So we need to do more, and we should do more, but it's not easy. How high a percentage, above 5%, should we spend? I don't know the answer to that. But I know that sometimes prevention will save money, and sometimes it will not. But this, in my judgment, is not the point. So if you ever find yourself in an argument with someone about whether an ounce of prevention is worth a pound of cure, I would argue, avoid that argument. That's not the point. Prevention is good in and of itself, even if it costs more than cure. Okay? So it's not just about proving that prevention is worth it financially. We should care about doing these things, about increasing the health of the public, regardless of whether it costs money. Maybe even because it costs money. Many prevention initiatives depend upon policy changes, as we've seen, that are outside the traditional health policy world or outside the conventional medical perspective. And we've seen many examples of that over the past semester. We saw how excise taxes on tobacco and alcohol products, or the passage and enforcement of non-smoking laws, was relevant to health promotion. We looked at the development and implementation of safety standards for workers and products. We saw some evidence regarding zoning approaches to enhance recreational opportunities or reduce the density of bars or environmental temptations. Another topic is the establishment and monitoring of environmental standards for potential hazards, or the adoption of community water supply standards such as fluoridation. We didn't discuss that, but you can see how there's so many different ways or so many different fields outside of what we might think of as health policy that are relevant to the production of health. An assurance of truth and reliability in the marketing of health-related products is another example. And finally, deliberate investments in social capital, even though seemingly outside the health domain, we saw evidence for how they might actually improve the health of the public. And these are all examples of important prevention efforts that not only touch on, but also are often entirely dependent upon, actions across a broad spectrum of the political and policy arena. Now, despite the stability of many patterns, social change, while difficult, is possible as well. Only the briefest of historical glances at what our society was like 100 or 50 or even 20 years ago can confirm that socioeconomic status, attributes of, and cultural attitudes towards health-relevant phenomena in our society have undergone dramatic change. Everyday things in your lives have changed dramatically, whether you are aware of it or not. Smoking has declined overall. Condom use has increased dramatically. In many schools around the country, there are free condom dispensers in the laundromats. This was not the case when I was in college. Condom use when I was in college was seen as sort of not something that was commonly done, but now is widespread. So that's a very dramatic change and about a very personal behavior, sexual behavior, in just the generation that has taken place. Seatbelt use and helmet use have increased dramatically. Ask your parents whether they wore their bicycle helmets when they rode their bikes. They'll say no. And yet nowadays this is seen as a normal thing to do. People wear their helmets. So things can change. People change their behaviors all the time. Gender and race relations have changed. Attitudes towards homosexuality and a host of things formerly seen as very difficult to change have progressed dramatically, even in the last 10 years. We elect an African American president. Within 5 years, I'm convinced that every state in this country, or 10 years, will support homosexual marriage. This is a very big change in principles or ideas that were held to be very dear in our society. So other things can change too. Our ideas and our attitudes regarding health and the production of health also might be able to change. So I'd like to advance an argument that we may be reaching the end of medicine. And I mean that in two senses, that we're reaching the end of medicine. First, for basic reasons of biology, we have an intrinsic mortality. There must be limits to what medicine can do for us, at least in terms of our longevity. So with respect to the Olshansky-Alstead wager, I side with Olshansky, at least for the next century. We can't live much longer than we are. There's something fundamental about the object against which we are banging our head against that cannot be changed in a significant way. Second, I think we're reaching the end of medicine in another sense. Because since socioeconomic advancement seems to explain most of the health improvement we've seen in the last century, and most of the persistent problems, I think we're approaching, indeed, I think we may already have reached, the limits of what medical care can do for us, can do to advance the health of the public. Since social and population factors, and not medical ones, are so important in explaining both why longevity has improved and why there are problems still. The point is that medicine may have done most of what it can do for us. We're not going to get to do it again. We're not going to get to invent 20th century medicine again. Hence, I do not think that it is to medicine that we should turn so as to cure our ills. I think it is to public health and to social science. We need to think more expansively about what causes illness in our society. Healthcare can deal with illness and disease, but a lack of healthcare is not the cause of illness and disease. And to quote social epidemiologist Ichiro Kawachi, it's like saying that since an aspirin cures a fever, the lack of aspirin must be the cause of a fever. It's not the right way to think about it. The cause of the fever in our society is not the lack of health care. It is, as we have seen, so much more. And I say all of this that I've just said today, and I've said the whole semester, I say all of this with the deepest appreciation for the strengths and values of medical care, and as someone who also knows and really understands how powerful and effective medical care can be much of the time. My own biography should be ample proof of my fealty to medicine. I grew up in a household where serious illness was afoot. As the child of a chronically ill and seriously ill parent, I spent my youth fascinated by the workings of medicine, both personally and abstractly. And I spent decades caring for seriously ill people on the brink of death. And I've seen life-saving drugs and procedures close up. I've seen these technologies work in real time, in almost magical ways that could not help but make a huge impression on anyone who saw them. And this is, in fact, one of the deepest conflicts I feel. I am intimately familiar with the life-saving power of medicine. In fact, so much so that I want to tell you a story that I struggle with and have struggled with for many years. Because many years ago, one of my colleagues told me about how he saved a man who had a bullet in his heart. So this colleague of mine was a surgical chief resident, and in those days, I don't know if they still do it, but in those days, the surgical chief residents were literally resident in the hospital. That's where the word comes from. You lived in the hospital. And as a surgical chief, you were in the 5th or 6th year of training after medical school. You completed your internship and your residency, and you'd apprentice to be a surgeon, learned so much surgery. When you were finally a surgical chief resident, you were obliged during this year to live in the hospital for 3 months. So you would live in a little apartment that was right next to the emergency room so that you could be immediately available should a patient with a serious illness be rolled into the ER. And you slept there, and only once in a while were you allowed to leave the hospital and someone else would take your place to go visit your family. Actually, you would have conjugal visits. Your partner would come in and stay with you in the apartment so that you literally never left the hospital. And on Saturday nights, in most urban settings, most urban hospitals around the country, we have what doctors used to call the knife and gun club. So on Saturday nights, lots of patients would be seriously injured because of violence. And one day, this doctor was called immediately as a patient was being rushed in. So the ambulance calls ahead, the patient has been shot, he's in the ambulance, they pull up to the bay, they put the patients on the gurney, they're wheeling him in, they're calling ahead, and my colleague is quickly putting on his shirt and leaving his apartment to go into the emergency room to intercept and meet this patient there. And he arrives within seconds, and he sees right away that the patient had been shot in the heart. And there's an entrance wound in the chest, and as he begins to examine the patient, he sees that there's no exit wound. So the bullet is still inside the patient. And the patient was wheeled to the trauma bay, and he was dead. He was in asystole. His heart wasn't beating. But this friend of mine decided to prep the patient anyway, to put the betadine on his chest and to call for the equipment and to crack his chest. And so you make an incision with a scalpel down the midline, through the skin, you get to the sternum, and then you kind of saw the sternum with a little circular saw, you just cut it like this, and you put in this big kind of reverse vise that clips in, and then you crank the vise that like opens up the chest wall, like the ribs and bones are just opening up. And I asked my colleague, I said, "You did that without anesthesia?" And he said, "Yes, the patient was dead." Why would you anesthetize a dead patient? And he takes his gloved hands and he slips his hands into the patient's heart, into the patient's chest wall, and he feels around the heart, and his finger goes into a little hole in the right ventricle. And if you're going to be shot in the heart, about the best place you can be shot is in the right ventricle, as it turns out. And he puts his finger into the hole, and he puts his other hand behind the heart, and he can feel that there's no hole coming out of the heart. And then he can feel the bullet jostling around inside the patient's heart. So he feels it, this little bullet, like inside the heart of the patient. And only then did they start administering anesthesia. Patient's been cut open, ribs have been taken over, your hands are in the patient's chest, you get your finger in this guy's heart through a hole that's been shot. And now they start administering the anesthesia to this patient. And he fishes the bullet out with his fingers and with some tweezers. And then he begins to inspect the patient's heart, and he sees that there are no lacerations on the coronary arteries, the arteries that supply blood to the heart, that come out of the aorta and encase the heart and provide a blood supply directly to the heart vessel. So he's checking to see if those are lacerated, if those are cut, because that would be a problem. But they're not, they weren't cut. And then they start cardiopulmonary bypass. The patient hasn't had a heartbeat all this time, right? No blood's been flowing through the patient's body, and now they start doing the clamping and connecting the patient to a machine that's going to start the blood flowing through this patient's body. And then my surgeon friend proceeds to do a more thorough procedure, sort of cleaning up, beginning to stabilize the operating field, inspect what's happening, look for other injuries, and complete his operation. And the patient lived. Came back to clinic weeks and months later, seeing my surgeon friend, waving at him, talking to him, surviving this whole episode. And I asked my friend, I said to him, how did that make you feel? To have operated on a patient so dead that he did not need anesthesia when you cut open his chest, and to have saved his life, to have brought him back from death. And my friend said to me, it made me feel like a god. I don't think it's so funny, though. I think that's just incredible. It's incredible that our civilization has produced that kind of an ability, that kind of training, that kind of technology, that kind of skill, that you can take a person that's shot in the heart and that is so dead that you can crack them open and put your hands in their chest and bring them back so that they are so alive, they walk into clinic and say, hi, doc. It's just unbelievable. And it's really hard to reconcile such stories with the claims I've been making in this class, isn't it? I mean, it's really difficult to hear a story like that and make sense of everything else that we've been discussing this semester. And I, too, have had personal experiences similar to this, though nowhere near as dramatic and on a much smaller scale, because I'm just an internist. And I've had the moral, I once read stories by William Osler, a famous physician from 100 years ago, describing how people died of pneumonia. And Osler would talk about these cases. A young woman in particular, I remember reading a case study of a 20-year-old woman who died at Johns Hopkins Hospital when he was there of pneumonia. And I read the case story and I thought, I can walk into that patient's room and lift my pinky and save her life. And it just broke my heart reading this little drab medical text describing this case of this woman who had died. And I've had many, many experiences like that. I've seen powerful drugs work. I've eased psychosis, eased pain, cure infections, cure the heart, save people's lives myself, doing much less dramatic procedures than what I've shown. And so I struggled with this dilemma a lot, about the intersection of the natural and the social sciences, about the role of medicine, about the relative importance of social factors, and so forth. But even so, I nevertheless believe that medical interventions are increasingly cosmetic when it comes to enhancing the health of the public. Indeed, they may even distract us from the true nature of the problem, and from perhaps more convivial, more effective, and perhaps more important, more just solutions. Because after all, why was the man shot in the heart in the first place? Why are 2% of deaths in the United States due to firearms? Why are 2% due to medical errors? Why are 6% due to poverty? And why are 20% of deaths in the United States due to tobacco? It's so easy to be besotted and seduced by this godlike power that we lose sight of the actual nature of the problems at hand. And we focus our attention where it doesn't really belong, losing sight of how we might actually make the health of the public so much better. So I'm not saying we should ditch medicine, just that we should know its limits and its utility. I'm going to close with just a couple more ideas. Because I think perspective. This perspective on medicine, this disposition, fits more broadly with what I regard to be good qualities in the way one should lead one's life more generally. Good qualities such as humility and breadth of thought. I think that if you want to live a good life, you have to have these qualities. And if you want to understand the health of the public, and if you want to make the world better in this regard, you have to have these qualities. Things are rarely as simple as they seem. And in fact, it's arrogant to think that they are, or that we can fix human suffering with any one approach. It's a kind of hubris, too, to think that all we need to do is invent a new widget, or a new drug, or a new technology, and that's going to somehow solve the problem of illness and death in our society. Given how intimately connected health is to the social and natural state of human affairs, it's hard not to take such issues seriously. What are we, as a society, to do about illness and suffering in our midst? To what extent and how must we respond to the sources and consequences of this state of affairs? Do we not need a public health response to address the kinds of things that we've been considering this semester? And I think, and I'll leave you with this, I think there are moral issues at stake here. Issues of what kind of life we want to lead, and what kind of opportunity for life, liberty, and the pursuit of happiness we want everyone in our society to have. Thank you. Thank you very much. See you around.